So we're going to start with Eric Augereaud's presentation. He has a practice in Boulogne-Billancourt and is going to do a study club. It's already in progress. Hello, everybody. Thank you very much for being here. It's an honor to be able to talk to you, and I'd like to thank AUGERAUD for having given me the floor one more time. What I'm going to say might be an echo to Ariel's presentation and even to my relationship with Charlie. I knew Charlie at a time when he was still working for Omedan and not Autoplus. We used to play tennis, well, not play tennis together, but play tennis in the same place. We no longer play tennis, either of us. Now we work in the field of orthodontics. Apparently the screen is frozen. I'd like to start by introducing the Ortho Study Club, which could have been called the Genius Study Club. It's a study club in the old fashion. There are no more study clubs. I mean, they were very popular at one stage. Study clubs were very popular when I started working. There were study clubs on tweed, on rickets, and now there are no more study clubs. There is the Elika Lab full study club, but that's it. And yet it's interesting because it allows to bring together a group of people who work on the same subject. We call it by calling it Orthodontic Study Club, it's a very far-reaching study club. I don't know how to do this. Well, we tried to limit ourselves to the Genius system, and the Orthodontic Study Club targets students or young orthodontists who want to improve their knowledge or want to receive a bit of support from more experienced people. It also targets more experienced orthodontists who want to share their knowledge, pass it on, and learn from other experienced people who respond to the questions. I'm the administrator, and I've learned a lot with the answers provided by Ariel, Yaman, Bilal. And they learn from me because we sometimes disagree. And they think, okay, he's done it that way. That was nice. So we have some interesting cases, and we're going to discuss them. So we're not judgmental. We have a lot of goodwill towards each other. Every time somebody is in the waiting room, it freezes the whole thing. So we organize a meeting every 3 or 4 months. The first one was in June. This is the second one. We postponed it for December to be able to hold it during this summit event. I start with a clinical case or clinical presentation quickly, and then I give the floor to the members of the study group. The members will send me cases, ask me questions, and I will submit the case to some experts, and we discuss the cases together, and we reply to the questions and to the person who submitted the case. It's very interactive. We have a lot of freedom because even somebody who is a beginner can give an opinion. Maybe that person will disagree with the others, or maybe we will disagree with him, but it's very friendly and we respect each other, and the point is to exchange opinions. I'll show you some examples. A brief presentation. I helped design the Genius system a few years ago. I'll show you some pictures. And I was also one of the key opinion leaders for Clever Liner that we're going to discuss tomorrow. I'm a member of the Genius team. The Genius team are the people who want Genius to improve and make progress in practice so that we can reach the excellency that we're aiming for. I studied in Missouri, and surprisingly, you know what happened in St. Louis, 1917? That's where orthodontics was created, was invented, Edward Angle. This picture was above my chair in the university. That's where orthodontics were created, and the orthodontic center, Edward Angle's orthodontic center, has become an orthodontic center for the university where I graduated. And St. Louis' emblem is St. Louis's arch. It's almost like an arch wire. It's gateway to the west. That's where all the migrants headed for California, for the western reaches of America. Not United States at the time, it was just America. And I was trained. Not with this gentleman, but with all the, all the professors, all the lecturers were there. It was awful. It wasn't even Tweed at the time, it was then two from Merrifield. It's just the history of orthodontics. This is where my practice is located, in the western side of Paris for the last 30 years. I have been a professor in the Tel Aviv University together with Maurice Strauss. We taught students the passive ligating technique with Damon devices. And I left the university because I thought that in the university you had to be very open to all the brands. And they were very locked with a single brand, and I did not agree with that, so I thought I'd leave the university. Nowadays, I am what they call a genius. What? I told you about the initial days of Genius, 2015. This is the XXL prototype. Held above my hand. Michel Zayag and Georgina were there. Catherine Lasvernius as well. I mean, there were four of us. In the meantime, the team has grown. It's bigger. This is a map. I may have made a few mistakes, but this is the distribution of Genius since 2015. North America, Japan. It was already being sold in Japan, but in May we're really going to Japan. You're welcome. We're going to celebrate the Japanese way. I don't know exactly what that means, but, well, the cherry trees will no longer be blooming, but I hope there will be nice weather. Briefly, many innovations, many stages in Genius, brackets and arch wires in 2015, Genius arch distalizer in 2016. I'd like to show this picture because we're going to discuss it later in my presentation. This is the Genius Arch Distalizer, 2019. I'm trying to remove those black windows. I made a mistake there. Thank you. So I don't know what switch I'm going to click on. 2019 version V2, 2019. I was introducing Genius Sagittal first, that some of you have been using to replace the Genius Bar. 2021 Indie Bond, beautiful presentation earlier today. The new sequence of Genius arch wires that was mentioned earlier. And finally, the auto-partner support, because auto-partner doesn't leave you alone with brackets and the build. They have a digital lab, And the digital lab is working really well. There's a Genius Academy with classes, with a master, with summit meetings. They're supporting us. And even since 2024, we've had the Genius Study Club. The first study club, there were 100 participants, approximately 50 in the room or 40 in the room, and then 50 on Zoom. They'll be very unhappy. I can't admit people because they're still waiting on the in the waiting room. Can someone help me? Can someone, Oriel or Fanny, go on Zoom and admit the people? So we discussed many different things. We showed a complete case. We talked about treatment strategies. We talked about very interesting things, impacted second molars, troubleshooting, the kind of cases we're going to show today. We start a case with Genius and we have an issue. What do? Either we just try to address a problem on our own, or we share the case with other people to find some inspiration elsewhere. We talked about open bites, deviation, 45-degree rotation of a molar, difficult to correct. And then we played the games, what kind of games we're going to play today. Bring out your mobile phones, by the way. We're going to be doing some surveys with WhatsApp. You all have your mobile phones? You have your mobile phone? For those of us who are listening and who are on Zoom, we can't hear you, but some of you have left their microphones unmuted. So if you could please make sure your microphones are muted, otherwise we will have too much noise. So we're going to go to the Genius Summit New York 2024 WhatsApp group, and I will share some polls or surveys. So 1, 2, 3, 4, you can vote. We'll try and make the presentation interactive. The digital group in the study club on WhatsApp is made of 182 members, 12 experts. We have 83 case studies, treatment strategies, issues with treatments in progress. We have shared information on cameras, or what the meetings they have attended during the days of orthodontics in Paris in November. I mean, we don't want to share everything. We don't want the forum to be oversized. I have implemented a process that is very helpful because we try to keep things relatively organized. If there is a case or a question, then the question can be asked as a private message, and I will then reprocess the question and the answer and post them in the group. And that may start a discussion, but I don't allow the discussions to start in all directions. Another list of experts that I'm very proud of. Ariel Becerra, who is here with AutoSafe, his wife, Michelle Becerra, AUGERAUD, myself, Eddie Calab, who designed the pool, is very active in our group, and he tells us, sometimes people say, I can use a pool because the guy representing the pool is with us, and he says, no, don't use pool. In this particular case, you shouldn't use the pool. And it's interesting for those of you who are interested. Bilal Koleilat, who stayed in Lebanon because, they have a difficult situation there. A man you've heard earlier, Catherine Vallas, who could not come this time. Hugo's here, Olivier Migaud, and all those people, all those experts. And for surgeons, so we have Jean-Baptiste Charrier, who's very happy to be a member of the group. Hasn't had a chance to speak so far because there were very few so-called surgical cases presented. I'm now starting the second edition, and we're going to start with strategic issues. This is the kind of question that I receive. This is a clinical question. I realized, I think it was October, there was the month of talk. Maybe because I didn't get the questions in January or July or September, but in October there were many questions about talk. And I thought maybe, people don't have the adequate knowledge, have some gaps in their knowledge. So I circled and highlighted in yellow questions that showed there was a bit of confusion, and I thought, okay, maybe we could do a reminder of how to manage talk with Genius. Initially, talk management with Genius was a single prescription with a prescription, a groove of which is much smaller, and a Archwire sequence, and normally you should be able to manage every single case with that, which is not true, but that's what we think. These are extraction-less cases, and extraction-less cases were treated with no specific talk management issues. One sequence of Archwires, one prescription, and somebody mentioned it this morning. What I really like is the fact that it was reproducible. It's very important. They're not twins, and yet we have reproducible results, because even in extraction cases, the top case was a premolar extraction case, 14 and 24. It was the contrary. It's 4 premolars and 4 premolars at the maxilla and 2 premolars at the mandible.
So what we're aiming for again is reproducibility. Wire sequence is the typical wire sequence that we're supposed to use for the majority of our patients. You have it on the screen here, the thermal ultra to begin with. So we start with 0.14 for 4 months, then the 0.8/18 thermal ultra, and then 19 by 25 beta titanium. So why this wire sequence? Well, I have a hard time, say to speak, admitting people on Zoom and talking at the same time. Yes, interpreters can sympathize. Doing many things at the same time is complicated. So you do that usually when you have crowding. We also use a pre-torqued wire before the 19 by 25 if we need more torque. And then stainless steel wires. I've said that for many years. In the large majority of my cases, I no longer use stainless steel at the end of my treatment. I finish with beta titanium in 19 by 25, unless I need to have elastics with a lot of force, because maybe the patient was not compliant at the beginning of treatment and we need more compliance, or if I need forces, or if there are some remaining spaces that I want to close. But except for these very particular cases, which make up about 5% of my cases, I do not use stainless steel. You have the thermal ultra genius, an interesting wire, in cases when you do not want to have too much expansion in the mandible, because the maxilla, to begin with, is small. Now, when you start with a disjunction device, you may see if you have too much enlargement in the mandible, you may have a discrepancy. So it helps with better coordination of both arches when you use thermal ultra. Torque management. Torque management for our 4 incisors is pretty straightforward. You have pre-torqued wires. For example, when you do not have enough torque in the maxilla, this is what you have. This is a patient we just started treatment on picture number 2. We use the pre-torqued wire in order to have right torque on the lingual side, but also at the root level. And what's important, you should avoid spaces to become open. So either you use a ligature in an 8 shape, or you use a power chain, and this again is going to prevent the pre-torqued wire to perform a torque on the buccal side. We just want to torque on the lingual side at the root level. So in the 4s, you have not enough torque. So we are going to use the pre-torqued wire. So it helps with torque management. When we use those pre-torqued wires on 4 incisors, I remind you that you can place it on the one side to have some torque at the root level, but you can also place it in the mandible. It does exist, the 19 by 25 pre-torqued. I think it's 24 and 28 millimeters, while at the upper arch, it's quite often 38 millimeter, and at the lower arch, it's usually 28 millimeters, but they exist for both arches, the pre-torqued wires. The other option is to start early when you need torque on the buccal side of the root level. So sometimes, you do not need to wait for the last steps. You can use the pre-torqued wire that you use rather early, and you can flip the brackets upside down. I think that both of you demonstrated that, and I will show you one of my cases where the brackets are upside down. So the class 3, on the class 3, you put the bracket upside down in order to have a torque on the buccal side at the upper arch and on the lingual side on the lower arch. So I suppose that you're familiar with the case. Well, it's a case by my colleague. It's a class 3 patient. As you showed, you bond very high, especially when you flip the brackets upside down for 2 reasons. Class 3, usually they show the mandibular incisors quite a bit, so you need to have more maxillary tooth exposure. When you expose the crown of your upper arch, it's a sign of youth. So you really need to, you look more youthful when you show more upper teeth. So you flip it upside down, and the slot, obviously, is not at the same level. It's going to be lower, if you will, as if it were in the right direction. So if you flip it upside down, you need to take into consideration the fact that your slot is not going to be positioned as it should. Beautiful case by Yamen sitting here. This is end of treatment. And the side teleradiograph. Again, I often get questions. For cases like those, before you use negative torque on the maxillary incisors, obviously, you need to have a look at the side teleradiograph. You need to know how much bone you have on the buccal side of the root before you apply more torque. And in any case, 18 by 25 beta titanium. And you need to follow up very closely on the patient. Careful if a patient lives far away, doesn't come back very often. That's usually, you need to be extra cautious with patients like us. So when you flip brackets upside down, you should have your patient at hand and be able to have a close-knit follow-up. So that was the superimposition of a before and after. Now we're going to talk about individual torque. How do we manage individual torque? You have a flip over. Flip over is very well known, especially for the maxillary lateral. It's not so much a flip over. The second case I want to talk about. You take a mandibular bracket and you place it at the maxilla, for example, for an impacted canine. So the impacted canine is going to be pulled, but usually the root is still in the palate when the canine is included or impacted. So if it's a 23, you're going to place a bracket of a tooth 45. So a bracket that is designed for the mandible, but we place it on the 23. And that way we are going to have a torque on the buccal side, and yet the slot will not be upside down. So it's using a bracket that's designed for the lower arch, but you place it on the upper arch, and you're going to see it's quite interesting. This is again for an impacted canine. So this is when you manage individual torque. Sometimes you have too much torque on the molar, either on the buccal side or the palatal side. Sometimes it creates an open bite, sometimes it creates prematurities. So again, when you use, for example, you are going to place a bracket that is designed for a 36, you're going to place it on a 1-3. It's just a form of crossover. The brackets that are designed for the lower arch are going to be placed on the upper arch. And I hope that you're still following me, says the speaker. There are cases where it's impossible. For example, lateral incisor. the torque that you need, sometimes you do not see the torque that you need at the beginning of treatment. But when you look at the occlusal view, you see that the root is really oriented towards the palate. So with a degainer, this is a degainer that we have here, you have a genius arch developer. So the root is towards the palate. We're going to use a spring to create more space for the impacted canine. And obviously, your root is going to go very high in the palate. So in such a situation, it's very interesting to flip your bracket upside down to get the right torque. Very targeted, very individualized. You need to be extra cautious. When you get the right torque for your lateral incisors, both frontal view and occlusal view, then of course you flip the bracket back in the right position. Sometimes you do that over time. If you have a treatment time of 15 months, sometimes you do not have time to bond your bracket in the right direction. But if the treatment is longer, for example 22 months, you should place it properly. You need to be careful because if you apply too much torque, then your root may get out of the socket. So you need to be very careful. This is 9 months of treatment with 19 by 25 thermal ultra. And if you look at the case more closely, I only have a few finishes that need to be done. So, in France, it's very specific because we have a number of semesters that are paid for by the state health insurance. So you do not want to have too quick of a treatment. So this is easy in cases like those to have an individualized torque. You create space, you use the 0.14 to create space. And then when you go to the rectangular wire, you see that the root is still very much in the palate. And in the occlusal view, you see that the torque has changed. Look, here and here on 2.12, you do see that the torque has changed, right? And this is what we see with the bracket being flipped upside down. You see that it's bonded very high. It's different between 12 and 22. 22 is bonded in the right direction. 12 is bonded upside down. And so the slot, as you can tell, is not exactly aligned. Something else which is a good sign is the level of the gingiva. When the gingiva is lower, sometimes, it's not always the case, but when the gingiva is lower, usually it's a sign that the root is more palatal for one root than the other. If the treatment is complete, sometimes you just do some laser treatment to change the shape of the gingiva, but if not, you need to be cautious with the torque. Now, there are cases where you do not flip the bracket. When you have a bracket with -6, for example, you're not going to bond a molar bracket. So, for example, here there's a discrepancy. 32 is very much pushed towards the lingual side, and so is the root. So what can we do? 0.14 to begin with. 7 months in this, I'm now able to bond on the tooth and place it in the arch. At the end, the crown is leveled, but the root remains far away in the bone. So I cannot flip the bracket upside down. So what do? Well, we continue the wire sequence. We go for 18-18, 19 by 25, but I still need more torque. So there are many ways out of this conundrum. And I managed by doing that. I know that you use a form of spring that beg. Usually, for those of you familiar with that, he would do that and that with the tooth. So you need a spring. That's Warren. Warren used to do that. Well, it dates back to the 50s. It was done with an Australian wire. This is something that I learned back in the days. So it's an old technique. However, I continued with my sequence, 1925 beta titanium, but that was not enough. So I'm going to show you the video that was shot by Ephraim Medina. You need that particular plier. It's a tool which I think is very useful. So lateral incisor, we know that we can manage that differently, but so you bond your bracket in the right direction and it just doesn't work. So either you rebond or you use the particular plier. Look, 15 degrees max. Again, it's beta titanium. If you do 25 degrees, either it's not going to work, or it's going to be painful for the patients. If it's a ceramic bracket, the ceramic bracket may break, so 15-degree max. So this is before, when the incisor was very much toward the tongue, and this is after when the talk is proper. Now, questions on strategy. In the study group, we receive many questions on treatment strategy. So treatment strategy is upstreams when the case has not started. So I receive many questions of colleagues. They have patients, they have not started yet, and so they want to have our opinion. This is a Brody case in mixed dentition. Those are difficult cases when you have a Brody syndrome. So here is a case. She's 9, young girl, Brody syndrome, crossbite. Well, we don't know if it's a crossbite because she has Brody. So this is the occlusal plane. You see B maxillary small arches. This is a case. Well, on the right, you see that the maxilla, of course, there's a lot of intruded teeth, lack of space for 33 and 43 front, which shows the maxillary occlusion plane is very much tilted. The side teleradiograph is not very contributive. I no longer do cephalometric tracings. When I do cephalometric tracings, it's only when I know that I'm going to present my cases. But we see that there's obviously a B maxillary protrusion, but that's typical with this ethnic background. So you see that 4-3 and 3-3 do not have enough space. And 2-3, we need to be careful because it pushes on the root of 2-2. So, front radiograph was not available. Would have been interesting to see the front radiograph. We see that the occlusal plane is canted towards the right. Intruded molars, incisors are not properly positioned. We do not have enough space for 33 and 43. Lack of space. Look, we see that very well. At the bottom, sector number 4 is intruded. Those are cases that you need to work on when they are in mixed dentition. You need to really intervene very quickly. It's a scissor bite. It's not a cross bite. The midline is shifted to the left, which makes us think that there's a sliding movement to the left. 23 and 22 are colliding, so many things that we need to take into consideration. So, it's like a show on TV. It's when you call a friend, or in that case, you call an expert. And so I asked 3 experts. I asked Yamen Labidi, sitting here, and I asked him, Yamen would use a functional device. He would extract 5-3 and 6-3 in order to help with the canines, and after 6 months is confident that the transversal dimension is sad, and in that case it will use a genius arch developer on both arches. And he confirms that it is what he would do. Ariel Abacera is here, and this is his proposal. Ariel is not doing functional rehabilitation. He starts immediately. Mandibular expansion with the arch developer to create some space for 3-3 and 4-3. So you expand the arch. Thanks to that, you hope that the mandible is also going to expand, but you help with crisscross elastic to expand up and upper arch and lower arch. Yes, but there's something missing, and you need ramps. Yes, I forgot. He forgot to include that he would use ramps. Yes, you need ramps, and ramps are key because you need to desocclude. If you don't place the ramps, it doesn't make sense. So you really have to place the ramps. And this is the answer by Bilal. Lingual arch, crisscross elastic, and ramps. I didn't forget the ramps for in his situation. And Bilal would extract 74, 84, 53, 63. But he has a lingual arch which maintains the space. And so extracting the deciduous teeth, less problems with crowding, only the molars need to be managed. So crisscross elastics, ramps. So ramps in order to desocclude. And this also is going to help with the cant, with the occlusal plane shifting, canting. So the mandibular molar is completely towards the buccal side. And so you can leverage that, the counter effect of off movements. Now, of course, many avenues, and there's no right and wrong. But this is what I suggested just because I had a very similar case in my patient base. So lingual arc, 4 millimeters to develop the lower arch. Elastic to help with occlusion. Ramps. Ramps are difficult to place on the molars, so you start on the incisors, behind the incisors. And then when it's possible, so you place the ramps on 1/6 and 2/6 to intrude sector 1 and sector 4. So three different experts, 3 different opinions, and that's only fair because it's a difficult case. But then eventually we agree on the use of ramps, the use of elastics, and lingual arch, crisscross elastics. This is my case. Pretty similar. We see that the palatal cuspid of the molar is really colliding with the antagonist cuspid. So I need to correct that as quickly as possible because if not, I'm going to have a very deleterious impact. Side teleradiograph, where you see that there's a bimmaxillary protrusion. We know that, but it's mixed dentition. So lingual arch active, crisscross elective, which starts from the lingual arch and goes down to the buccal side, lingual side of the molars. Well, doesn't help with the vertical dimension, but in this patient, there was no intrusion of the molars, so it was simpler than the initial case. So it helps in repositioning and correcting of transversal dimension. And now the patient, you have the lower bottom picture. In 6 months, we were able to get to that stage. So this is a Brody syndrome, mixed dentition, and we tried to address the case for our colleague. In the study club, we do polls or surveys, and I'm going to show you an example. I will try to make that as interactive as possible. This is a case where a colleague was not sure whether he should or should not extract. And yes, there's a risk for the profile. You're not sure whether all the teeth are going to find their space on the arch, but there are concerns from a periodontal point of view. So this is the side teleradiograph, which shows that there's a discrepancy to class 2. And there's a tendency to a proclination of the incisors. It's a slight proclination. This is a pan X-ray. And this is what we got with the poll. 25 people took the poll, and generally colleagues would extract the first premolars. Now, what would have you done? And I have a case for you where you can play. So do you have your mobile phones? If you do, you go on WhatsApp and you can vote. So different options, either you extract or you don't. So I'm preparing the poll, and I'm going to show you the case in a minute. There are many treatment options. I'm going to present the case and show you option 1, 2, and 3, and you're going to vote on WhatsApp. The patient is 14, female, and our colleague wonders whether you should extract 1,4 and 2,4, or maybe you could use a carrière, sagittal first, to do distalization first. And the colleague, of course, do not want to increase proclination of the incisors. So the cases you get, usually you need to think about the orthodontics side of things, but you need to think about the aesthetic point of view. So those pictures are not very nice. I mean, he's not very good at taking pictures. You have there's a blur around the teeth, so your pictures are not the best, I have to say. Occlusal view. Those pictures, I suppose, are key to the decision making. When you look at the patient's profile, well, I agree that the upper arch is slightly protruding, but again, there's an ethnic background which explains why. So that's the smile. This is the pan X-ray, which is not highly contributive. This is the side teleradiograph with, again, this incredible blur effect. I don't know how they managed to do those horrible pictures, but that's not the question. And you can tell that this is a skeletal class 2, and there's a tendency to incisor protrusion. Those are the questions. So you choose 1, 2, or 3. I'm going to present the 3 options. So option, I'm sorry, it's written. So first option is on Genius, on the Genius WhatsApp group. I'm currently typing. This is only for people here in the room. So, and now you can vote. So if you look at Genius Summit New York 2024, you can choose 1, 2, 3, or 4 on WhatsApp. And so, well, age of patient, she's 16. She's 16. C5, C6 is the maturity level from a vertebrae age. Is between C5 and C6. She's 16. So the maturity of the bone is quite advanced. Aren't you asking the question to a study group? No, you're not. Too many things at the same time, says the speaker. Only 10 people have replied. Yes, because we're thinking about it. Well, take your time. Take your time. So class 2, slight discrepancy of size in between both arches, age 16, C5, C6 in terms of maturity. And you have your different options. Extraction of 1,4, 2,4, extraction of 1,5, 2,4. And why not 1,5, 2,5, 3,5, and 4,5 being extracted? All 4 of them. Well, but then, yeah. If you extract 1,5, 2,5, 3,5, 4,5, you're going to use many elastics, and that's not necessarily the point. Someone changed their mind. I have about 40 participants. With bracket in wires, obviously, treatment option is going to be bracket in wires. So, well, you have the different options on the slide. So you want to correct class 2, 1/4 would extract. I conducted the poll in the group. And it was almost a 50-50 divide. So half of us would correct the class 2 and half of us would extract the teeth. Usually, class 2 correction, our colleagues would say, well, it's complicated because the young girl is 16, C5, C6, there's not much growth potential. So they would rather correct the class 2 and not extract. That was the rationale. But again, I would have corrected the class 2 with Genius and then reassessment with teleradiograph after a couple of months to see how we are making progress. But I keep a second option and extract afterwards. So I start with class 2 correction, see what we get, and then potentially extract the teeth. If I manage to retrude the lip, it would improve the mouth. Thank you for participating to that poll. I'm going to show you another case.
That's an example of question strategy that are being asked in a study group, and we answer those questions. It's rather interactive. It's interesting to see that although we are very confident, when we see that there are 25% orthodontists who would do something different from what we do, it will make us think, oh, he did it that way, so why? Genius case studies, problem shooting, problem resolution, questions, decisions. Conditions. All the advice given is only advice, and you're always responsible for the treatment that you're giving your patient. We ask questions, but if the diagnostic elements are not exhaustive, then the advice has a limited value. This is very artistic. To look at the case up front, you have to try and stand in front. The majority of the cases, the pictures are taken from the computer. I know all the computer brands. They actually shoot a picture of the computer screen. Very few cases of dental discrepancy. Profile is relatively normal. The pan X-ray, about the fact that the molars have already been treated, nothing really special. We don't really know the incisor area. Lateral cephalometric, slight protrusion of the mandibular incisors. The profile is a bit convex. So bring out your mobile phones and I'll start the post. What age? I have to remember my case. It's not one of my cases, but I remember, I think it's 12 years old. 12, 13 maybe. Question mark. 1, 2, 3, 4. Yes, no extraction. It's number 6. It means you place your device, your disjunction device, your... Combo means no extraction. Then it's you combine one of these items. It's no extraction, but a combination. Class 3 elastics, stripping, mini screws. I mean, I couldn't give you 20 different options, so you can make a combination. Pan X-rays here. That's very diversified sample of answers.
Bon, voilà, il y a une majorité qui est en train de se dégager.
We have a majority over.
Comme les élections, je me prépare.
It's like the elections. I'm getting you ready for the upcoming elections. Yes.
Je vous laisse encore une minute.
I'll give you one more minute.
Celui-là, je vous le dis, il va mal tourner. Hein. Je vous le dis à l'avance.
I'm telling you, this is not going in the direction you think it is going, but you can't change your replies. No one for lower incisor extraction?
Bon, il y a une grande majorité quand même qui s'est dégagée.
That's a majority in favor of no extraction. I might not have extracted the wisdom teeth immediately, but I would have done stripping and either microscrews, mini screws, or class 3 elastics, just so that the stripping would go in the right direction. Just to optimize the stripping, to optimize the front teeth alignment. This is the message I received. Hello, doctor, I hope you're well. I have a problem in my clinic. I have a patient with a dental discrepancy. I did a bit of stripping, 4.4 millimeters, but it was not enough. And this is my problem. So it's edge to edge. She did 4 millimeters stripping posteriorly and 2.2 millimeters anteriorly. But here you see necrosis of incipient necrosis of 31. And she says, I don't know if it's due to occlusal trauma or if there was another kind of collision. She's right. It may happen. The edge to edge actually was the cause for necrosis, the edge to edge contact. That's probably the reason. Unless there was a trauma on the mandibular incisor. So, extraction of the mandibular incisor, but I don't want that because he's a teenager. Please don't send this on your group. I'm not very proud of this case. I told her, don't worry, your name will not be on it. And she's a very close friend. She's not proud of the case, but honestly, I think it's interesting. Most of us said we're going to do stripping. Maybe the patient did not wear the elastics. Maybe. Yes. Maybe the wisdom teeth, I don't know, he's very young. So what do we do now? Because we have to give her an answer. I won't tell her her name. That's the pan X-ray. I was very uncomfortable with the opinion poll. I did one with a confirmed necrosis and one with unconfirmed necrosis. The tooth is grey, but it's still reacting to cold temperatures. It's a delayed reaction, but still. And it's happened before in the literature. Teeth that would sort of resuscitate. You give them PCR and they resuscitate. So we did an opinion poll. Okay, let's do it. Honestly, I can understand you would hesitate what to do. 1, 2, 3, 4, 5, 6. One is 31 endodontic treatment, no extraction, class 3 elastics. 2 is 31 endodontic treatment, no extraction, mini screws. 3 is 31 endodontic treatment, no extraction, more stripping. And 4 is the same, no extraction with combo 1, 2, 1, 3, 2, 3, or 1, 2, 3. 4 is endodontic treatment, 31 extraction of 4 premolars, the 5 sort of 6s, and finally we have extraction, 1 lower incisor.
Extraction des 7, mais j'ai pas mis extraction.
No, I did not include extraction of the 7s. Could have.
Alors, bon, bah, je crois que. Alors, hein? Première avec l'extraction. Première avec l'extraction. C'était super compliqué d'avoir 4 postures. C'est pour ça que je.
It was very difficult to have 4 different options.
On parle beaucoup d'extraction dans la sagesse. Ici, à la première
We talk about extraction of the wisdom teeth here at this table.
Le patient, les germes, ils sont vraiment tout petits.
The germ is still, the bud is still very, very small. It's just to make room to push everything backwards. There's no pressure from the wisdom teeth, they're still very small.
Le germe est tellement petit, en général, vraiment pratique, je n'extrais jamais de germe. Parce que je considère que le germe de la dent de sagesse, quand on pousse dessus, il recule un peu et il s'enroule. Par contre, une fois que la morphologie dentaire et la dent de sagesse commence à se confirmer, à ce moment-là, ça devient un bloc. Donc sur la photo initiale, d'avant la nécrose, sur la première radio, je ne voyais pas l'utilité. Mais sur la deuxième,
bon, on a quand même.
What we did,
Vous êtes moins nombreux à voter là. Hein.
there are less people voting on this particular poll.
Le 6 qui se dégage, extraction
6 is coming out, extraction, 1 lower incisor. I mean, the tooth is necrotic anyway. Maybe we can place a crown later. It's bimaxillary protrusion. It's an emergency. That would be a good solution. Number 1 as well. Number 4. We try to salvage the tooth. And if the necrosis is unconfirmed, well, that's the main issue. I advised the colleague, I said, look, if the tooth is still reacting to cold temperatures, you might want to preserve it. You have to make a decision. You don't know whether the tooth is dead or vital. Or we're not going to go over that because we won't finish in time. But I'd like to move to case number 2. Case number 2 is fantastic. I told you the pictures that were not really up frontal. I showed you the ones with the out of focus area. And here we have a patient sending 6 pictures, but I said, look, can you have something else before and after the initial pictures? Do we understand where it comes from? Because what you're giving me is not really conclusive. This is the case. Midline deviation, edge-to-edge contact, incisor edge contact.
Et la panoramique.
Pan X-ray.
Et la télégraphie de profil. Alors, vous avez vu.
Cephalometric radiograph. He sent me the panoramic of now and the cephalometric radiograph of before the treatment, so it's very difficult to match them. We tried to give him some advice, but the pictures weren't very useful. We insisted on the fact that we needed more documentation to understand the case. The first thing I'll tell you, and you'll tell me if you agree, you can challenge me, no problem. To obtain a functional deep bite, you want the mandibular or maxillary incisors to be changed, and you also have to use posterior bite blocks. But before that, there were some, but maybe they need to be bigger. And otherwise, you have to create a positive overjet. Otherwise, there will be no overbite. Patient is still on edge-to-edge contact because there was back control of the incisors, but it's mostly the Bolton, the dental-dental discrepancy, very tiny lateral incisors. So we say it needs to open space for possible veneers and obtain a class 1. And once we have a positive overjet, then we can extrude the maxillary incisors to have more deep bite. But if the patient says, no veneers, I want to keep those teeth, then we perform mandible stirruping micro screws. But in order to bring back the mandible, we have to bring back the mandible in order for the patient to have some overbite, some coverage. But before we cover the lower teeth with the upper teeth and we obtain some positive overjet, we have to start with the goal in mind and establish a treatment strategy for a renewed treatment, because that is already an old treatment, so you have to restart the treatment and you have to take a decision, but you need more diagnostic elements. Some strategic decisions have to be taken upstream with the patient, if a patient is an adult, or with the parents. Do we open space? Do we do stripping? The occlusion will not be ideal, and we have to start the treatment from scratch. Here we use genius brackets, which are well bonded, from my opinion. Doesn't really show on the picture, but seems to be okay. So she can use those brackets and rebond the 4 incisors. That would be it in terms of strategy. So what are the keys for success with the treatment, with the Genius treatment? And that's what I focus on in the study club. Genius system with bonding and timing and archway sequencing, the auxiliaries, the strategy, because there's often a lack of strategy. Oh, there are too many unanswered questions. What do I want to do? And I hesitate between 2 options. And that's what opinion polls are useful for. You are several people and you can take an inspiration from the trend that emerges. And the last factor to succeed in the treatment is patient cooperation. And apart from giving an electroshock to an uncooperative patient, there's nothing you can do. For those of you who want to register for the study club, you may do so by flashing this QR code. It will take you directly to the registration form. We can do it for you if you need help. It's a forum for exchanges. It's a family. Everybody can speak. If some of you want to become experts because they believe they're very good and they want to be experts, fine. Come to me. Come forward. That's my Instagram account. Okay, some of you are taking pictures. Please subscribe to my Instagram account. You'll see where I go on holiday. And I told you about the way the WhatsApp group works. If you have questions, if you have clinical questions, you can drop it, post it directly to the whole group. And if you have pictures, then you forward the pictures and I will have a discussion with you and the experts and I will provide some answers. Next study club will be April 2025, September of 2025. And as the Americans say, thank you guys. Well done, Eric. Questions?
I have a question. Yes. Not for you, for all of you. I thought that, I'm sorry, I can't.
Oui, mais ils n'ont pas des casques.
French, but I can speak with you in French. With you or with the other orthodontist. In first, you always do fixed upper retainers.
The question was, in France, you always use fixed retainers, upper arch?
In the upper arch, yes.
Just the upper arch.
The upper arch, we tend to bond wire retainers from 2 to 2 or 3 to 3, depending on the case.
Because I saw all of you using fixed retainers in the upper arch.
Yes.
And normally,
because statistically speaking, it's easier to handle some wire retainer breakage than relapse.
Okay. That's what.
But I do agree that the ideal retainer is the removable retainer the patient wears every night, so there's no breakage. It's easy. It's easier, but the mentality of the French people is not towards wearing a retainer every night, like in America, for example, for like 10 years or 20 years. They won't do it most of the time.
I have a question. How long to do expansion on the upper arch? You talk about the Brody syndrome. How long for the upper arch expansion? Well, with the lingual arch, 3-4 months. I have a question regarding Brody syndrome. You never use a plate for a maxillary contraction? I've never tried the reversed strut plate. However, Bilal said on the mandible you can use a plate with a strut to do the expansion, but then you become dependent on the patient's cooperation. But why not? For mixed dentition, the patients will be okay, they will cooperate. It's alveolar. It's alveolar, basically. More questions? The pool for the Brody syndrome. I remember that he took the floor in the study group to say it was not an indication. I'll check that. Thank you.